Hi, that's Walid Tawfiq. This is another case scenario. 70 years old woman with severe left knee pain. Describe what you see and tell me how you are going to manage this case. So this is a clinical photograph and a plain radiograph of the left knee showing severe valgus osteoarthritis. There is a severe valgus malalignment on the clinical radiograph, on the clinical photograph. On the plain radiograph, that's an AP view. Uh, not not annotated as a weight bearing or not showing a medial joint space opening, lateral joint space narrowing with subcondylar sclerosis. This is a severe degree of valgus osteoarthritis. I would like to see other view, including lateral view and skyline view and shoes view. So I will the differential diagnosis for valgus knee, including osteoarthritis, inflammatory arthritis, or previous surgery like lateral meniscectomy. I will assess the patient by taking a history, including history of the present complaint, ensuring the pain is originating from the knee. I will ask about history of red flags that can suggest a serious pathology. I will do an Oxford knee score. What's the treatment received and what's the outcome? What's the patient limitation and expectation? I will ask about the any other joint history that can point out to inflammatory arthritis or ipsilateral hip problem. Ask about medical history, how the patient is fit if we embark on surgery as a treatment, any history of inflammatory arthritis or immunosuppression. I will do my examination general looking at the patient BMI or any suggestive features of inflammatory arthritis. Local examination, I will overall alignment, skin condition, looking for scars or previous surgery. Ask the patient to walk to check for gait. I will check her any point of tenderness and effusion, extensive mechanism and patellar tracking function, range of motion, check for fixed flexion deformity, and I will examine the cruciate and the collateral, especially the medial collateral ligament and correctability of the deformity. Finish my examination by examining the neurovascular status, hips and spine. My investigation will be imaging in the form of plane radiograph, full weight bearing of the knee. I will obtain a long leg alignment view. I will do a CT scan only if I have any concern about bone deficiency. Lab investigation, I will do basic bloods, full blood count using ease, and I will do cross match if I plan for surgery. My aim of treatment, any intervention, is to improve the patient quality of life by achieving a pain-free, stable knee with restoration of the normal mechanical alignment, joint line, and normal patellar tracking, and balanced gaps between flexion and extension. And the guidance about that is a nice guidelines about primary osteoarthritis management. And the principle is specific for this case. It's a complex case. So options of treatment either by non-operative treatment, and if I assume that this patient had exhausted the non-operative treatment and she's symptomatic enough and fit enough to go for surgery, I will offer her a total knee replacement. And the outcome of that intervention, up to 90% satisfaction rate with 15 years survival of the implant. And the specific challenges, preoperative and intraoperative and postoperative. Preoperative, I need to manage this case as a multidisciplinary approach, including the anesthetic team to optimize the patient prior to surgery, doing a cross match. Uh, I need a senior knee surgeon to get it right first time with preoperative planning, and they should prepare different type of constraint to address the medial collateral ligament laxity. If it is completely intact, I would go for PS knee with patellar resurfacing, a cemented implant. If it's deficient but still intact, I will do a condylar constraint knee. If it's completely deficient, I should have a rotating hinge knee replacement. And as a rule of thumb, any level of constraining or augmentation, I should use a supplement on the femoral and tibial side with the stems. Other specialties, if the patient had a history of rheumatoid arthritis, I need a cervical spine X-ray. I need to have a rheumatology review and the medications to be reviewed prior to surgery, and definitely involvement of the rehab team. Intraoperative exposure, I will do my routine medial parapatellar approach and look for any previous scar or extensor mechanism alignment procedure. On the femoral side, I have to be careful about my femoral rotation, as there is a lateral femoral condyle hypoplasia and that can lead to internal rotation of the femoral component. And solution for that, I need to use a wide side line. On the tibial side, I need to address any bony defect. As regards soft tissue, this patient had a lateral soft tissue tightness. So after I do my bony cut and try to and balancing the knee, if I find the lateral tightness, I will start by taking osteophytes capsule followed by the iliotibial band from Gerds tubercle and popliteal tendon. Very uncommon. We do pike casting of the lateral collateral ligament structure, and as a rule, if I did that, I need to think about a high level of micronestraining. As regard the post-operative, there is post-operative routine. This patient is a higher risk of common perennial palsy, so I have to concern the patient about that. And they both need prolonged rehabilitation and my routine post-operative DVT prophylaxis.